Hello everyone, my name is Lewis Hodder. I'm an advanced care paramedic working out of Brisbane, Queensland, and today we're going to be going through a synchronised cardioversion of an unstable, broad complex tachycardia. So for the safety precautions for this scenario, we're going to have to wear a face mask, a mask with a filter, a gown, glasses and gloves, as well as adhering to the 5 moments of hand hygiene. For the purpose of this scenario, we will not be wearing all this equipment, however. So just to summarise where we're at, so we have Anika, 55-year-old female, obese, has presented in a broad complex tachycardia at 170 to 180. Following this, we've had an ECG interpretation and had a look and identified some AV dissociation with a heart rate of about 170 to 180. So our provisional diagnosis has been VT. Her blood pressure was about 130 systolic, so we considered it stable VD without any signs of APO or MI in further assessment. So our initial assessment and treatment for Anika was the placement of pads and the administration of fluids IV. We've got about 200 mils so far, and the administration of aspirin on scene. We were preparing for an infusion, but we have noted a significant deterioration. So I have Mitch here, who's an advanced care paramedic, and we have Alex, who is another critical care paramedic assisting me on this case. So noting the acute deterioration, Mitch, do we have a radial pulse there, mate?
No, I can't feel a radial pulse.
I note that she's still conscious. I do have a carotid pulse. Airway is uncompromised with no adventitious sounds or signs of obstruction. She is breathing independently. Mitch, do you mind doing a full reassessment for me?
Yeah,
emphasising perfusion status assessment, respiratory status assessment, and a conscious state assessment as well to get a GCS. Alex, given that we've identified we have a conscious patient with a carotid pulse in VT, I think we'll prepare for a procedural sedation.
Yep.
So to do that, can you please draw up for me 100 mics in 10 mils of fentanyl? Yep. And can you draw up 5 milligrams in 5 mils of midazolam?
Can I just check that fentanyl with you? Fentanyl, 100 micrograms in 2 mils, and it expires 08/2022.
08/2022.
Perfect.
Right, so from here, guys, we're going to prepare for a resus in case we do descend into cardiac arrest.
I've got those obs back for you, Lewis.
No worries at all.
I've got GCS 12, so...
GCS 12, yep.
Yep, eyes are 3, voice is 4, motor's 5. Blood pressure is currently sitting at 60 on 35.
60 on 35, yep.
ECG has not changed.
Okay.
Pulse rate matches the ECG as well with the carotid. I can't feel a radial. Got a respiration rate of 30. And in the mid zone there's some fine end expiratory crackles. SpO2 is 91% on room air.
No worries at all. Thank you for that, Mitch. So just in regards to airway breathing and circulation, airway-wise, we've already preemptively, with our airway assessment, identified she's obese and put her in the sniffing position here and ready. Given that she's got low SATs, Mitch, can we please give some oxygen at 6 litres per minute?
Yeah,
we have adequate ventilation, so I'm happy not to go down any kind of PEEP, BVM or CPAP route. Given that she does have crackles, that may suggest that she's got left ventricular failure and may have some signs of APO secondary to her arrhythmia. I don't think CPAP is of any benefit to this patient given our blood pressure is so low, and the same goes for GTN, so we can't do much there but treat symptomatically. As far as circulation is concerned, it's obviously critically low. At a blood pressure of 60 on 35, we could go into cardiac arrest in any minute. We have a grossly unstable tachyarrhythmia here that's a broad, complex and regular. Whether it's VT or SVT with aberrancy, the definitive treatment is the same, and that is cardioversion. This is the most efficient way to get our patient back into a perfusing rhythm. As far as our cardioversion goes, ideally we would be sedating this patient, but our usual sedation goals would probably usually be about GCS 12. So there's probably not a lot of benefit here from giving sedatives, especially given it's midazolam, and we're going to see an increase in that hypotension and possibly descend into cardiac arrest. We're going to forego the benefit of an amnesic effect if we do go solely with fentanyl, but I think it's a risk that we have to take given how unstable she is.
I agree.
So I feel like there's not much benefit from that. However, I do think we should be pushing some low-dose analgesia. So do you have that fentanyl there, Alex?
That's the fentanyl.
No worries at all. So I think the plan is, guys, is we'll give 25 mics of fentanyl.
Thank you.
25 mics of fentanyl in 2.5 mils. We'll do a synchronised cardioversion. So we've already got the pads anterior lateral. When you're ready, Mitch.
Yep. Cool. Fentanyl.
And from here, we'll charge for 100 joules, 150 joules, 200 joules. We'll have 3 attempts, and then from there, if we are unsuccessful, we'll go code 1 to the closest ED that can handle this. Other considerations as well, we do need to do an ECG beforehand to check that the monitor is identifying the R waves correctly as well. So we'll just go to manual mode.
Fentanyl, 25 micrograms at 12:45.
Thank you, Mitch. Oh, thank you. And are you able to print out that ECG for me when you're ready, Alex? Thank you. And then just go to 100 to start, and just confirming we're still not in cardiac arrest. No, we're not. Are you guys happy with this plan and where we're at?
Happy
Yep,
at this
happy.
stage. Yeah, I agree. She's unstable with a blood pressure of 60 systolic.
You'll note here in the comparison of the European and Australian resuscitation guidelines, the management of tachyarrhythmias. For regular, broad tachyarrhythmias that are unstable, the definitive treatment is electrical cardioversion in both cases. Why do we do synchronized cardioversion instead of normal DC cardioversion? Well, the answer lies with the complication of shocking a patient in their relative refractory period. The reality is that we can induce VF if we do this. Shocking immediately after the QRS complex also results in a greater rate of resolution of VT. How many joules should we be using? Well, a stepwise approach is recommended, and often ventricular tachycardias of the pulse usually respond to energy levels of about 120 to 150 joules, such as what we'll be using in this case. There are two obvious pad placement options for synchronized cardioversion. That would be anterior lateral and anterior posterior. This study attached obviously looked at AF, which is not VT, so therefore limited, but AF actually requires often a higher joulage for a resolution and therefore is more sensitive to probably impedance. Thus, we can deduce from this, given that there was no difference between anterior posterior and anterior lateral, that there isn't a huge difference with pad placement.
Yep, so that's the ECG. It's picking up the R waves there, and we've also got it in sync mode on the monitor there.
Wonderful. And SpO2, has that come up a bit to 94?
Yeah, yes, it has, yep.
All right, so from here, guys, we're just going to charge. I'll just have a brief explanation to Anika. She may not be able to understand, but that's okay. So Anika, we've just identified that you're in VT, as we probably talked about on scene. You've obviously become a little bit unstable, so we're going to have to shock you, okay? It's going to be a bit traumatic, but we're going to be with you every step of the way. I'll let you know when it's about to happen. Okay, guys, so let's charge, and we'll just move oxygen away. So confirming, everyone clear, shocking, okay, Anika, here it comes. Shock delivered. Okay, Mitch, do we have a radial pulse? And can we get an ECG again?
No, I can't feel one.
I've still got a carotid. It's still very fast.
No radial.
No radial there.
Still in VT on the monitor.
Still on VT on the monitor. Okay, Anika, unfortunately that one's been unsuccessful. So what we're going to do from here, we're just going to move up to 150 joules. Once that one's printed out, we can confirm that we're still in VT. Still in VT. Okay, Anika, we're going to have to shock you again, I'm afraid. Just charging. Okay, everyone's clear. Clear, shocking the patient. Okay, shock delivered. Do we have a radial pulse? I have a good carotid.
Yeah, I can feel radial.
Okay, that's good. All right. SpO2, I've noticed, has started to drop again. We'll just get this back on. Mitch, can you do another reassessment for me? So our considerations from here, guys, is that obviously we may have an underlying cause of this VT. It could be maybe an electrolyte disturbance. It could be a myocardial infarction. I think we need to crack on with the management of the signs of the APO and the left ventricular failure. So if we can get GTN on board, if we can get CPAP on board, we'll consider that. However, she's obviously a very brittle patient. We'll do another reassessment of a 12-lead ECG as well. Yep. I think from here, given that we have reverted, I think the greatest benefit to this patient will be going to a facility with ICU, CCU, in interventional cardiology. So I think we will bypass that local hospital, code 1. I think the way we'll transport will be me and Alex in the back, and Mitch, you can drive this vehicle.
Sounds good.
It's okay with you. Do you have any other considerations or concerns, guys? It's important to talk about with the considerations and post-cares, particularly the causes of VT. I've just listed a couple there. Probably the big one being ischemic myocardial infarction in this patient, and investigating that 12-lead ECG.
Not at this stage. Have we got that blood pressure back now?
Yeah, any luck with that one? I think it's at, 130 on 90, good.
Excellent, and that heart rate slowed down too.
Wonderful. If we do revert back into VT and we are stable, we can continue with that amiodarone infusion as well.